Demi.
Hi. Well, thank you everyone so much for being here today. I'm Demi Thomasides, and as I begin, I want to address one very important facet of my positionality. I love Grey's Anatomy. With that being said, in season 5 of Grey's Anatomy, the creators introduced Dr. Virginia Dixon, a cardiothoracic surgeon with Autism Spectrum Disorder, or ASD, whose character arc lasted all of 3 episodes. In the show, Dr. Dixon was hailed for her precision and speed in the operating room, while simultaneously ridiculed for being a little off. She's been criticized as a stereotypical portrayal of ASD who creates an insensitive and inaccurate view of disability. The need for an academic and honest critique of neurodiversity in the media is long overdue, as the majority of discourse runs through popular sources and is often unsustained past its air date. So, as a student new to disability scholarship, the development of my methodology was dominated by a necessity to understand the intricacies of critical disability theory. Before long, it became apparent that nearly the only unifying theme of CDT was the lack of unification beyond the base level understanding of disability as a social construct, meaning that it's not necessarily the impairments such as the autism spectrum disorder, but rather the social process that turns that impairment into a barrier of access. The scholars explain, however, that this disunity is not necessarily a bad thing, as it encompasses a vast range of individual experiences and understandings. The consensus among these scholars is that by not having a singular definition in this postmodern world, critical disability studies, in fact, exhibits theoretical sophistication, especially given how the individual definition of disability ranges so much intrapersonally and even fluctuates within a person's lifetime. Thus, disability requires an adaptable definition to hold any value as a social justice lens. I propose a methodology that creates a space for surveillance studies within critical disability theory, much in the same way that feminist theory plays an integral role in the field. I will engage with post-panoptic thought by evaluating Dixon's inclination to mask as a form of internalized surveillance. I'll begin this analysis by evaluating a visual and verbal othering of Dixon as a basis for her need for internalized surveillance in the first place. Indubitably, this methodology will also employ a feminist critique by analyzing neurodiversity as it intersects with the presentation of femininity, examining Dixon's positionality as masculine within the gender binary. This methodology allows for an examination not just of the misrepresentation of ASD, but the normalization of penalizing a person on the sole basis of their disability. On to the analysis. So I found that through her vibrant red coat, as seen in this first photo, and choppy language, Dr. Dixon is positioned as other within Seattle Grace. It's a positionality that creates a significant obstacle when trying to succeed as a surgeon. Her bright red coat and beanie, in contrast to the paleness of her surroundings, are both visual markers of her otherness and an indication of the intensity in which her disability is both portrayed and received. Additionally, there's a concise rhythm of speech between the doctors that force outsiders to either contort themselves to the Seattle Grace-related jargon or be forced out completely. This creates an incessant intolerance of neurodiversity. As Dixon deviates from this fast-paced dialogue, she's isolated from workplace camaraderie. The verbal othering is most prominently seen through Dixon's simplistic sentences, as she uses no more than 8 words at once, with frequent repetitions of "I do hearts." The choppiness and childlike nature of her speech are not enough to contend with the intricate, information-packed dialogue thrown around by the other surgeons at Seattle Grace, and it creates a reason for the doctors to mark her as other, as if her lack of dialectical homogeny validates their judgment. Because of their social capital, the surgeon's adverse reactions towards Dixon validates a negative response towards disability and normalizes a standard that Dixon should be condescended towards and disrespected, despite her vast surgical accolades. Dr. Weber uses his power to diagnose Dixon as a little off, And in a show full of medical professionals, this othering illustrates that prefacing disability as adverse is reasonable, objective, and even doctor approved. The harm of which is that Seattle Grace's reaction towards disability is paralleled in our real life. So on to masking. The show's failure to adequately acknowledge Dixon's neurodiversity suggests a possibility that she may have decided not to reveal her disability in the first place, inferring a reliance on masking in the work environment. I contend that masking is a colloquial understanding of internalized surveillance, which is based in post-panoptic thought. While post-panopticism is a broad term that largely refers to a less structured dispersion of power, one where we do not need to be watched because we are already watching ourselves, it encompasses the idea that individuals with autism, oftentimes women, work to hide their ASD traits in order to homogenize. While a forced depiction, Dixon's compulsion to overemphasize typical introductory courtesies paints a painful image of a woman with ASD, both keenly aware of the way her traits position her in society, and a woman who's working to mask those traits in order to succeed in an ableist coded environment. Finally, within the confines of the show, Dixon is characterized as other. Within the confines of academia, however, Dixon is personified as the infamous medical model, an antiquated yet pervasive way to examine neuro and physical divergence within the field of disability studies. Because the model strives for a cure rather than a shift in paradigm, the doctors at Seattle Grace are unable to distinguish Dixon's impairment, her autism spectrum disorder, from her disability. Once again, that social process. For example, Dr. Dixon has proven her skills and speed in the OR room, yet she is unable to attain the role of head of cardio. The ASD does not impact her ability to effectively perform surgery, however, the other's reaction to her disability does. Finally, Dixon's success as a neurodivergent doctor is based in a gender binary that categorizes disability as masculine in an attempt to explain her extraordinary success despite her neurodiversity. The main tenets of the gender binary, as seen through feminist theory, are active-passive, public-private, logical-emotional, and sexual subject, sexual object. In each of these dualities, Dixon, a white woman, falls into a masculine characterization. She is an active and successful participant in the masculine coded environment. She is a member of the public sphere, once again, relying on her career as a means to build a sense of self. Most prominently, Dixon is logical, in one episode going as far as to say that it is, quote, good a teenage patient went brain dead as it fulfills the needs for another patient's organ transplant. Finally, Dixon counters the idealistic sexual female body through her position as an androgynous being. Her scrubs are boxy in comparison to her female coworkers, whose white coats snatch at the waist and emphasize that hourglass figure. In all cases, ambition is masculine and used to justify success despite disability. So, wrapping up, studying Dr. Virginia Dixon was my inaugural analysis into critical disability theory. The published work on disability is overwhelmingly provocative, and I want to thank all of those thinkers who I've both known and read that have helped me in this inaugural analysis. Through my experiences as a family member and ally, I crave a world where disability is both acknowledged and valued, and as a newborn scholar, I envision a reality where critical disability theory is practiced intersectionally, keeping a physical and social equality at the forefront of our society. Thank you so much.